Hello and welcome to the Guide Educational Online Library and the Novo Biocare portal. My name is Steve Perrell. I want to talk about a little bit about immediate loading and the all-on-4 concept, but I want to talk more specifically about some of the things we're able to do as a result of the all-on-4 in treating patients who in previous times, in previous days, may have not been able to even have implants. The all-on-4 has been, and I hate to use this term lightly, but it has been life-changing for patients and practice-changing for many clinicians. I'm living proof my life changed when I first saw the all-on-4 in 1992 in Portugal at the Malo Clinic. And since that time, I've been involved in utilizing the concept. It's not a product, it's a concept. Using the all-on-4 concept in a number of different manners, a number of different applications in patients I've had, both in an institutional and a private practice setting. It has made a huge difference. It's made a very dramatic change in how we practice dentistry today, and it's made an even more dramatic change in the lifestyle and lifestyle ability that many of our patients now can enjoy as a result of an implant full arch restoration. So I'm going to talk a little bit about expanded applications. I'll talk some about patients who might not have even been able to have implants without some sort of pre-prosthetic application on a previous time, such as a bone graft, such as osteotomy, such as moving maxillas and mandibles around. Some of these things we can now avoid. We can simply use implants to a much greater effect by simply incorporating the concept of tilting them. It seems simple. You might wonder why nobody thought of it before, but they didn't. It really came around in the early 1990s, and as a result, we're able to enhance the position of our implants, enhance the stability of our implants because they're longer, and actually with an increased anterior-posterior spread, use more immediate load than we used to be able to use. It's very much a state-of-the-art, state-of-the-science concept, and it uses in many cases only 4 implants to attain what we used to do with many, many more. The expanded applications are illustrated first in this individual who has bone volume issues. Now you don't see, if you look at the radiograph, the panoramic film, or if you look simply clinically in the mouth, you do not seem to see a patient who has severe atrophy, who might have bone issues as far as enough bone to support implants or even a denture. It looks like a fairly normal patient. In fact, a fairly normal, if not good, ridge in the maxillary region. If you look, however, at the CAT scan, the cone beam, the CBCT, you'll see that this patient does indeed have very thin alveolar processes. And as you get into the basal bone areas, you'll see that there is very little bone in many, many regions of this maxilla. If you compare the maxilla on the solid model, which you see on your left, to the mandible, you'll see that the bone itself is almost appearing to be non-existent. That's because the bone is so soft and non-existent in thin form compared to the mandible. Of course, you know that the bone of the maxilla and the bone of the mandible come from different areas. One is endochondral, one is intramembranous, and they are, by very nature, by very design, different densities. The mandible is always stronger, always more dense as it appears to be so in the lower picture of the solid model. The upper jawbone is sometimes hard to find. And in this particular case, the reason is the bone is very thin. I like to try and use apical triangles. I like to look at the bone in the area of the base of the basal bone to see if there are triangles we can engage with implants. This patient 10 years ago would have been a bone graft patient. In order to get enough bone to place implants in vertical positions, the patient probably would have been grafted. Today, however, because we can angle these implants, because we can enter through the maxilla palatal to the ridge crest and engage more bone by the angulation of the distal implants especially, we can use 4 implants, the all-on-4 concept, to allow this patient to not only be immediately loaded, which is exactly what you see has happened here. You can see the temporary cylinders, which means that this is the same day that the surgery was done, that this prosthesis was placed, and those temporary cylinders are now connecting to the implants which have just been placed so that the patient can enjoy an immediate load restoration over a period of the next 4 to 5 months while those implants heal. The final restorations are then placed, and we end up with a result that looks something like this in a patient who was severely compromised as far as the amount of residual bone remaining is concerned. The all-on-4 concept allows us to treat patients like this more effectively than we would have in previous times. There are modifications you can make to this all-on-4 concept. We don't have to have just the distal implants be in angled positions. We can also angle the anterior implants. Ole Jensen and Mark Adams wrote a very nice article on this concept back in 2009, where they illustrated various ways to enhance the length of our implants and still engage the very best bone in the apical triangle region. I was practicing in Dallas for a number of years, and we started off trying to do the very same thing in more of a free-form fashion, as you see here. It took us a while, but we got a little bit better at it. We got to the double V, we got to the M's. We used it on the lower jaw as well as the upper jaw. There is nothing that says you can't angle every implant. Traditionally, if you think of All-in-4, however, it's just the distal implants that are angled, and in many cases, that's all you need to do. But in the patient with inadequate bone or compromised bone for some reason, angling all of the implants can enhance the end result. In a patient like this who appears to have on cross-section all the bone you would ever need for an implant to be placed, you by examination and more complete look at the CAT scan itself find that that bone is not very dense. Because we have what I consider the best diagnostic tool we've ever had in the history of dentistry, in the CAT scan we can tell. We can use the Hounsfield unit indicator as part of our software that comes with this particular cone beam unit and evaluate the density of the bone in this patient. We can see that if you look carefully, we have numbers in the areas where the bone appears to be softest, all of which are under 100 on a mean value scale. In our center, where we use this machine for every patient, I can use 100 as a baseline. And any patient who shows up with numbers in the 30s, 40s, and 50s is a patient who has soft bone, and I need to let them know. I need to let them know that if we are going to place implants, we may not be able to immediate load because your bone isn't as dense as we would like it to be. If the patient says, why, I've had a denture for years, my bone's just fine, all you have to do is show them the picture on your right. The picture of the solid model where you can picture the lower bone being very dense and very bright and very shiny and find almost no bone at all in the maxilla. As soon as the patient sees that, and it's a very good patient education tool because there's no blood involved, there's no bleeding for the patient to be afraid. If they see that, they begin to take ownership immediately of the problem that they have. This is not a problem of not having enough bone, it's a problem of having not enough dense bone. And the patients are almost always heavy smokers. That shows up very early on, that shows up easily at the time of our initial examination. All I have to do is tell this patient, we're going to put implants in, we may get 35 Newton centimeters, we may get 70 Newton centimeters, depending on what site we're in and what kind of bone we run into, but we may not be able to load you immediately like we do some of our other patients. That's the time that the patient needs to find out that that is a possibility. You don't want to ever have to wake a patient up who is expecting to have a fixed restoration in their mouth and tell them we had to do a denture because the implants weren't strong enough. Always make sure that the patient is pre-informed. The CBCT is a valid predictor of the type of bone you will run into, and in consequence, a valid predictor of some of the torque values you will probably encounter as you place implants. This particular patient, you can see, has healing caps on the maxilla and had a denture. About 5 to 7% of the patients we do treat in that very busy private practice environment were patients we could not load immediately. Although we did eventually in this patient get onto a final fixed restoration without any failure or loss, these patients need to be informed way ahead of time that their bone is not strong enough. This particular lady had very nice bone, very dense bone, but the best torque values we could get in any of the implants was only 35 Newton centimeters using an implant, the active, which we anticipate should give us 70 Newton centimeters of torque value of initial stability every time we place it. She knew in advance that the implant prosthesis that she eventually had to wear would be a denture in the maxillary arch. I wasn't happy, she wasn't happy, but I didn't have to tell her when she woke up that this is the situation we encountered. She knew that it might happen. And if we let her heal long enough, the key being anticipation, we will end up with a prosthesis over these implants that has been hollowed out so that there is no contact against any of the white caps or abutments, and a final restoration eventually at 3 to 4 months that is essentially the same as what we might expect for any other patient. We simply weren't able to immediate load. This is an occurrence which you may find as well. We found it 5 to 7% of the time when we were doing these on a daily basis. And in some cases, as you see on your far right, we actually did not even expose the abutment because the bone was so soft. Simply going old school, going back to the original concepts of osseointegration that Professor Bronnermark taught us, leaving the implants alone underneath soft tissue with a denture over them for the 3 to 5 months, whatever, depending on which jaw you're operating in, was allowed for healing to occur. And that particular patient on your far right ended up with the final restoration just like the others, with no consequence, with no failure of any of the implants. Additional expanded applications might include patients with skeletal occlusion and various other anomalies, such as this Class II individual with failing dentition, a lot of breakdown, and a significant Class II jaw relationship, which not only affects the aesthetics, but also the functional ability many of these patients have. For years, individuals like this have been treated and still can be treated with orthognathic procedures, with orthodontics, with all kinds of jaw manipulation processes. Today, however, if the patient has failing dentition, if it's a terminal dentition individual, we can affect the very same thing we used to do with all these jaw movement procedures simply with implants. And the simple process of controlling the cantilevers allows us to do that. These cantilevers in a Class II patient, of course, will be stronger in the anterior and less strong in the posterior. So we have to make sure that as we place these implants, we angle the anteriors so that they minimize the extent of the cantilever projection from the anterior dentition back to the premolar area. By angling these anterior abutments, we can have the screw access holes come through in a reasonable position. You'll notice that this final provisional restoration, even with the first molar on it, still has no cantilever at all. That's because of the posterior position of the mandible. But as a result of using the implants and managing the cantilevers with angled abutments in the anterior, we were able to reproduce a Class I occlusion immediately, which for a number of individuals is something that is dramatically effective, dramatically important to them. Now no longer are they biting on the roof of their mouth. Now no longer are they having to worry about an inverse plane of occlusion or an less than ideal aesthetic effect. This patient can simply perform as if she had all of her life, teeth in their proper position. We were able to convert this individual the day of surgery into a nice Class I occlusion, repeatable under sedation with a jaw position that she could bite into on her own with the kind of result that you see right here, and implants placed as you see also in anterior-posterior spread relationships that are favorable for both immediate load and long-term reconstruction. About a month later, she came back, and this is the occlusion that she presented to me. I asked her to close down again with her tongue in the back of her mouth. I put my finger on her chin to manipulate the jaw. I tried everything to try and get her back into the Class I position that she had when she initially presented at the time of surgery. Also, at the end of the surgical process, we were in a better occlusal state, but we now cannot repeat it. You can, after 1 month, move the lower prosthesis backwards. It's a laboratory process. It takes several hours, but you can do it. And that's exactly what we did. We moved her back to a re-indexed mandibular position, as you see here. Saw her in a couple of months later, and now she's way, way back. Now, because she had no original proprioceptive occlusal position that she could repeat, she now has still no home for her occlusion. It's not a terrible situation. She is all over the place with her occlusion. She probably will end up, and she did in fact have monoplane occlusion as a result of having all of this ability to translate in all different directions, and she's perfectly happy with that. She's used to having, not having an occlusal position she could repeat. Now it'll take several months, maybe even a year, before she can come back to her original position. Be aware that that's a possibility when you're utilizing implants to correct an occlusal discrepancy like a Class II. The Class III patient, on the other hand, is much easier. These are vertical chewers. These are patients who have only one occlusal position. And in this case, it's an anteriorly positioned mandible rather than a posteriorly positioned mandible that you have to deal with. Look at the solid model. Look how the teeth on the maxilla have splayed. Look how they have moved out and away and simply have risen almost to a horizontal position as a result of the forces of the lower jaw being so far ahead of the maxillary bone and alveolar process. These patients can be treated much the same way in a cantilever sense, simply the reverse, however, of what we saw with the Class II patient. Rather than having the abutments angled towards the anterior, these abutments now angle towards the posterior. And by utilizing the concept of simply having the angle of the abutment approach the center of the opposing ridge crest, which is what you see on your left, we have a pretty good position for creating and recreating a Class I occlusal relationship in a patient like this. which is exactly what we did at the time of surgery, class 1 relationship, and then on to the final restorations that look as you see here and on the right side radiograph completed. You don't have to worry about this patient ever giving you a different occlusal position. These patients only have one place they can bite, only one position they can bite down on. Vertical maxillary excess is a complication that occurs in some patients, sometimes called long face syndrome, where excessive gingival tissue is visible with a high smile position. It can be treated in a number of different ways. Classically, it can be treated with a Lefort osteotomy where the whole maxilla is moved upward and sometimes back a little bit in order to get that gumminess out of the way. That's when the teeth are in good health and you want to salvage the dentition remaining in this patient. However, if you have a patient with failing dentition and a gummy smile, such as we see here, with maintained interarch space, then sometimes you want to simply do implants alone to try and correct the vertical maxillary excess that this patient presents with. This is a case of a meth mouth individual, 35-year-old lady who overcame her drug addiction, now in good health, and simply has too many teeth destroyed to try and keep and repair any of those that remain. By evaluating the CAT scan, we see that we have plenty of good bone to deal with. We have good piriform length between the ridge crest or the incisal edge and the piriform base. Good apical triangles of bone. In fact, we have all the bone we need and all the density we need for a good result. But we have to plan carefully because we're going to try to raise the plane of this dentition some, if we can, and certainly try and recreate in a high lip line position for this patient a more pleasing effect with the patient smiling. We are carefully controlling the bone using the bone reduction guides we provide for this patient and every patient who receives a maxillary all-on-4 prosthesis, and by instructing the surgeon to remove enough bone so that I have 17 millimeters or so from the incisal edge to the base of the bone cut, I should have enough space in order to hide the transition line under the patient's upper lip. We can also place abutments using these guides that we make for the surgical reduction of bone. We can also use them to help place the abutments in positions that allow them to predictably come through the cingulum region of the prosthesis. The final result looks something like this in full final form with the bar structures underneath, and her final smile line looks something like this. Now, if you are critical, which I try to be, I will say certainly that that's an improved result. I think everyone would agree on that. But I think it's difficult to say that we have completely eliminated the gummy smile in this individual. It's probably impossible to raise the occlusal plane enough to do that in most of them because in contrast you have to raise the occlusal plane of the mandible as well in order to keep the VDO at the proper dimension. So if you just simply promise these patients perhaps an improved result, certainly that was accomplished, but perhaps not a complete reduction in the gumminess, the gummy smile that you perceive, they're probably still going to be happy because all of their lives they've been used to that gingival display. All you've done is reduce it some and make it a little bit more bearable. We can also expand the applications of the all-on-4 to the patient with existing pathology. If you look carefully at the solid model on your right, you'll notice extensive bone loss in that maxilla from apical regions, from periodontal disease, from infections of all different sorts. You have bone missing in this patient, which I would like to have present in order to place implants in idealized positions. In times past, this patient would have received an immediate denture. All the teeth would have been extracted. Suturing would occur to try and make primary closure wherever possible. Maybe even some bone grafting in the sinus region, the sinus area, to try and recreate some bone in the areas where the bone destruction, as you can see on these cross sections, is dramatic, all the way up to the floor of the sinus on that patient's right side, and perhaps even through the floor of the sinus on a couple of cuts. Perhaps, however, with the all-on-4 concept and some of the things we can do with immediate load, by extracting all the teeth, removing all the infectious process, and trying to use the residual bone which remains, we can avoid the process of having to wear a denture. Now, this is a stretch. This is not something you may want to do on every patient, but in some instances, we are able to try and do exactly what we've done in the other patients in the presence of frank and sometimes purulent infection. We placed implants in the posterior region on that right side, same on the other side, which wasn't as badly involved, in the presence of bone defects, as you see here, that are extensive. In fact, primary closure will be impossible in this patient. We will have to leave some of these areas defective and hope that secondary filling in and granulomatosis will take place. Over a period of time from June 2009 through a couple of years later, we were able to watch this patient and see how she did. Provisional restoration looked pretty good, but only a month later we started to see the incision line break down, we started to see some bone being exposed, and we started seeing what I thought was going to be the perhaps loss of at least 2 implants, perhaps a catastrophic loss of even more, and maybe a patient who we'll probably have to start over on at some point with implants after bone healing has occurred. But we decided to wait. We waited through December. We said some of these areas start to resolve themselves, but if you look at the radiograph, you'll see there's still some dead bone here and there. We also saw in February of 2010 that there was still some bone in the anterior region, which we still tending to extrude and eject itself from the oral cavity, yet these areas seem to have nice bleeding underneath, and the tissues themselves seem to be recovering in spite of all of the pre-existing infection. In fact, by the time we got to May of 2010, the area was all healed up. Everything was completely clear, and we were able to move on to the final restoration. So even in the presence of a frank infectious process, we were able to place implants and have a result, as you see here, that did not require that the patient receive and utilize a denture during the healing phase. These choices in patients like this will certainly vary. I'm not sure everyone is a candidate for something like this, but far more patients who show up with infection, who show up with destruction of bone, are still candidates for implant processes and implant immediate load than we once thought would be possible. Age as an extended application. You might be wondering why I used it, why I'm showing you one of my favorite individuals on the center of your screen, because she is a senior citizen. She's one of our older patients and one of my favorite of all time. She had one complaint. She wanted to be able to smile at her grandchildren when we first met. She has a history of some cardiac maintenance, but otherwise is pretty much in generally good health. You can see from the picture on your left that the teeth are broken down, badly broken down, and you can see why she wanted to be able to smile at her grandchildren. When she did smile, it frightened them. So she wanted to have to do something a little bit different. So we did all of the radiographic analysis and found that she perhaps had more bone than any patient I had seen before. And when we did our smile analysis, we also noticed that she had what many senior citizens present with, an inverted smile line. The lower lip now, because of the flaccidity of the face and the loss of tone in the facial structures, actually allows more mandibular dentition to show than maxillary. And when you're doing a rehabilitation, a reconstruction on a patient this age, sometimes this makes the mandibular arch the more important one, the arch where you have to focus more of your attention on aesthetics and do perhaps a little bit more bone reduction. And speaking of bone reduction, she had more bone than any patient I've ever seen as well. Look at the tuberosities. I've never seen them that large. If you see on this particular shot, the size of the tuberosities, the size of the tori and the maxilla as opposed to the tuberosities, there is magnificent amounts of bone in this patient's mouth, and you have some teeth that are not terribly destroyed, that are not actually in too bad a shape periodontally. Although one tooth is loose and there is some periodontal disease, some of these teeth are still healthy. When you go through the various options, dentures, fixed partial dentures, removable partial dentures, and implants, it's a difficult choice. It cannot be made easily. And of course, what complicates that choice is that she's 102 years old at the time we did this procedure. The implants became the option of choice. I didn't want to take away all the bone she had simply to make room for dentures or partial dentures. And trying to do fixed restorations on her may have required root canals in many cases, and I don't think there's even visible evidence of a canal in most of those teeth. Implants were the option, and we did them under general anesthesia. We had to be careful, of course. She's a living icon. We did it in a hospital setting under general anesthesia. The surgeon got a little bit nervous after the first several. Implants were placed and decided we better stop after only the maxillary arch was done. She healed like this after 1 week. Remarkable resilience in a patient that age. A couple of months later, we went back, finished the case, and about 4 months later ended up with this final restoration in her mouth. Remarkable lady. In November of 2014, she celebrated her 108th birthday. So she got 6 good years out of these implants. 6 years where she could smile at her grandchildren and actually enjoy her meals. And even though she's in a nursing home facility, she was the star. She was the bright light of the nursing home and one of my favorite patients of all time. Unfortunately, she died in January of this year. I attended the memorial service, but I was very pleased with what we were able to do for an individual who not only is senior in category, but also above senior in years of age, but certainly perhaps physiologically a great deal younger. The whole point of this exposure is to many of our patients are living longer. Many of our patients are maintaining their teeth longer than they ever did before. And many of those teeth are being challenged due to caries, due to extended disease, or simply breakdown. Because we can enter quickly with immediate load concepts, we can treat more of these patients than we ever thought we could in the past. And that's where the All-on-4 idea really comes into play in our senior citizen age group. How does this really work? Well, there was not for a very long time enough literature out there to really support utilizing the All-on-4 in the maxilla. One article in 2005 on a very few patients seemed to indicate we had high success rates, 97 or so. But it was several years later, many years later, almost 7 or 8 years before we started seeing some other reports indicating that we could use the All-on-4 in the maxilla more effectively. We're still waiting on a 10-year follow-up. We're still waiting for that 10-year follow-up from somebody on the All-on-4 in the maxilla. Although it does have good documented success rate, we don't have the long-term documented success that we would like to see. Paulo Malo, who is probably popularized, the one responsible for popularizing the All-on-4, presented in San Diego at the AO in 2009. And he did show 8-year follow-ups on both maxilla and mandible patients, a lot of patients, almost 2,000, a lot of implants, almost 8,000. Failed in the maxilla, only 39, failed in the mandible, only 8. Both success percentages are within statistically significant ranges of each other. There is no statistical difference in percentage of success, but there is a statistical difference between the failed numbers of implants. The maxilla failed 5 times more often than the mandible. Although you can quote good success rates, that failure rate in the maxilla is somewhat bothersome. There is a way to rescue the maxillary implants that I'm going to suggest to you, and that is simply to remove the failed implant and utilize an all-on-3 concept for maintaining the fixed restoration in the patient's mouth with a limited cantilever while that new implant heals. I am not a fan, and I do not recommend immediately loading a maxillary failed implant, especially in the distal site, until all implants have been shown to have been healed completely. If during the healing phase you lose an implant, you can set yourselves up for a catastrophic situation. I'll illustrate that in just a moment, but it has been documented that the All-on-3 as a provisional means of rescuing a patient who has a failed implant is a valid approach, and it's one we use routinely in the maxillary arch. You can come back, add the implant to the prosthesis at a later date, 4.5 months after the rescue implant was placed, and several months after impressions were made and the final restoration was delivered. The patient now looks like this and is functioning normally on 4 implants in the maxilla with 1 rescue implant in the distal right side. However, that experience was not repeated in this particular individual, who initially had implants that were strong, in good position, angled in, as you can see, various directions, but one I wasn't too worried about because the length of the implants and the torque values were very acceptable at the time of our surgery. Unfortunately, he lost a distal implant on the upper right side, and if you look at these series of radiographs, you'll see that he had what is called a cascade effect, where we not only lost the distal implant, but we lost the implants next to the distal implant, and right down the line, eventually losing all the implants in his mouth as a result, perhaps, of too much stress, perhaps as a result of him being a serious bruxer. We went from a patient with teeth to a patient with no teeth, and simply wearing a denture over healing implants a little more than a year later. This individual had severe bruxism parafunctional habits, as I eventually noticed in the wear patterns on the lower prosthesis. I wish I had been able to notice this at the beginning, and I might have made some different approach to his therapy, but as it turned out, we eventually went to every kind of implant we had, every graft technique we know about, to try and place as many implants as we could in this maxilla and get him to a point where we could provide him with a final restoration, which we eventually did. That's not a fun process. I don't wish it on anybody who might be watching this presentation, and it's one that I think we can avoid. We look back at our patients in Dallas, where we had that busy center and where we had placed implants for a number of years, and looked at our results as well and found we had very much the very same failure pattern that Paulo Malo talked about. 5 to 6 times more implants failed in the maxilla than they did in the mandible. However, our success rates were still in good percentage ranges. It's just if you do more implants, you'll find that you'll fail more times in the maxilla, and it's more difficult to deal with those failures. So I had a change in focus. We changed to prevention as a way of trying to decide how to treat patients at the treatment planning phase. And we went to a profiling protocol. I just simply made a list of all of the various things that I could think of that might cause an implant to fail. Of those things you see here, there may be more. We went back and looked at all the charts of these patients, and there were 41 total failures and 19 patients in those charts. And I noted by looking at some of these that a few of the potential areas of presentation seem to have higher incidence of failure than others. Opposing natural dentition against implants seemed to produce a higher rate of failure. Poor bone density, male patients, posterior implants all had higher rates of failure than did the others. I thought bruxism would be higher. It only occurred 8 times in the 19 patients, but it's still a significant factor. So what we did was try to identify the at-risk patient. Primary and secondary factors could actually be put together. We published an article back in 2011 on this very finding, and it really doesn't matter whether they're primary or secondary. If any one of these shows up, it's a red flag. If 2 of these show up, it's a bigger red flag. It's a patient who simply needs to be treatment planned differently. If a patient shows up with soft bone, we will place more implants today than we used to. I will ask the surgeon for 6, 7, 5 implants in a patient like this to overcome the possibility that one of those implants might fail as a result of simply having not strong enough bone for these implants to be placed in initially. This patient worked out well, 6 implants, but it's not an all-in-4. In fact, 4 is a misleading number. This patient had a surprise bone. In other words, a patient who presented with a nice-looking maxillary arch, who also presented with a panoramic film that seemed to show that there was plenty of bone all the way down to the alveolar process, actually had some of the thinnest bone I've ever seen. Some of the most atrophic maxillary knife-edge presentation in the alveolar region that you can imagine, which limits dramatically the amount of bone available for placing implants. We probably would have bone grafted this patient as well, maybe 10 or 12 years ago. But today, because we have this kind of diagnostic capability, and today because we can place implants in the palatal region and engage bone in those apical triangles by angulating in various regions, we're able to place more implants and get them effectively healed to be able to use them eventually in a final restoration. Ole Jensen wrote an article about the vomer implants, the 2 you see in the anterior, engaging that very dense bone at the base of the nose. Not many people thought about that originally when we were only doing vertical implants, but by angling today, we can improve and enhance that effect. This patient ended up losing only 1 of the 10 implants we placed. I ended up using 7 of the 9 that remained and left the last 2 in the pterygoid region as bailouts. I haven't needed them yet. The patient's done very nicely over time. Malo published an article in 2011 on the success rates in patients with compromised bone, 97.7% success. So patients who we didn't think were implant candidates in the past now can be, utilizing some of these angled implants approaches. The trifecta, my favorite. The bruxing patient with opposing natural dentition and a male, is the patient who can do tremendous damage, a patient who can inflict upon your restoration huge forces. In these patients, you have to place as many implants as you can. I strongly believe that. Even Dr. Malo agrees that those patients with bruxing habits, especially those like this one, with a limited opposing dentition and a highly stressed anterior component against the upper jaw, will need as many implants as possible to try and protect the occlusal forces these patients can generate. The single jaw, as you can see here, can cause a dramatic amount of change against opposing dentitions, and it has patients who need to be treatment planned with bruxing parafunctional habits are individuals which we will almost always, if we can recognize them at the diagnostic phase, use more implants and utilize those implants in longer, more spread out positions than we would in the traditional all-on-4 type individual. I thank you very much, and I hope you are able to gain some insight from this presentation that will help you perhaps treat more patients more effectively in the future. Thank you.
For more education programs, visit the Guide Institute at www.guidedental.com.